The posterior approach is the most common and practical of those used to expose the hip joint, popularized by Moore. 9. It is often called the Southern approach. All posterior approaches allow easy, safe, and quick access to the joint and can be performed with only one assistant. Because they do not interfere with the abductor mechanism of the hip, they avoid the loss of abductor power in the immediate postoperative period. Posterior approaches allow excellent visualization of the femoral shaft, thus are popular for revision joint replacement surgery in cases in which the femoral component needs to be replaced. Because access to the joint involves division of the posterior capsule, if dislocation of any prosthesis occurs, it will result from flexion and internal rotation of the hip. Thus, there may be a higher dislocation rate than that from anterior approaches if the posterior approach is used in fractured neck or femur surgery in elderly bedridden patients who often lie in bed with their hips in a flexed and adducted position. Their uses include the following. 1. Hemiarthroplasty 10 to 12. Hip replacement, including revision surgery. 3. Open reduction and internal fixation of posterior acetabular fractures. 4. Dependent drainage of hip sepsis. 5. Removal of loose bodies from the hip joint. 6. Pedicle bone grafting. 13. Open reduction of posterior hip dislocations. Position of the patient. Place the patient in the true lateral position, with the affected limb uppermost. Because most patients requiring surgery are elderly and have delicate skin, it is important to protect the bony prominences of the legs and pelvis with pads placed under the lateral malleolus and knee of the bottom leg and a pillow between the knees. Break the limb free to leave room for movement during the procedure. Figure 8-52. Landmarks and incision. Landmarks palpate in detail the greater trochanter on the outer aspect of the thigh. The posterior edge of the trochanter is more superficial than the anterior and lateral portions, and, as such, it is easier to palpate. See Figure 8-27. Incision. Make a 10 to 15 cm curved incision centered on the posterior aspect of the greater trochanter. Begin your incision some 6 to 8 centimeters above and posterior to the posterior aspect of the greater trochanter. The part of the incision that runs from this point to the posterior aspect of the trochanter is in line with the fibers of the gluteus maximus. Curve the incision across the buttock, cutting over the posterior aspect of the trochanter, and continue down along the shaft of the femur. Figure 8-54a. If you flex the hip 90 degrees and make a straight longitudinal incision over the posterior aspect of the trochanter, it will curve into a Moore style incision when the limb is straight. The final incision is curved and 10 to 15 centimeters long, centered on the posterior aspect of the greater trochanter, internervous plane. There is no true internervous plane in this approach. However, the gluteus maximus, which is split in the line of its fibers, is not significantly denervated because it receives its nerve supply well medial to the split. Figure 8-53. Superficial surgical dissection. Incise the fascia lata on the lateral aspect of the femur to uncover the vastus lateralis. Lengthen the facial incision superiorly in line with the skin incision and split the fibers of the gluteus maximus by blunt dissection. Figure 8-54b. The facial covering of the gluteus maximus varies considerably in its thickness. In the elderly, it is quite thin. The gluteus maximus receives its blood supply from the superior and inferior gluteal arteries, which enter the deep surface of the muscle and ramify outward like the spokes of a bicycle wheel. Hence, splitting the muscle inevitably crosses a vascular plane. In addition to the arterial bleeding, venous bleeding must be anticipated. If you split the muscle gently, you may be able to pick up, coagulate, and cut the crossing vessels before they are stretched and avulsed by the blunt dissection of the split. Obviously, vessels that are torn when stretched retract into the muscle and are more difficult to control. Figure 8-52 position of the patient on the operating table for the posterior approach to the hip joint. Figure 8-53 There is no true internervous plane. Split the fibers of the gluteus maximus, a procedure that does not cause significant denervation of the muscle. Deep surgical dissection. Retract the fibers of the split gluteus maximus and the deep fascia of the thigh. Underneath is the posterolateral aspect of the hip joint, still covered by the short external rotator muscles, which attach to the upper part of the posterolateral aspect of the femur. Figure 8-55. Remember that the sciatic nerve leaves the pelvis through the greater sciatic notch and runs down the back of the thigh on the short external rotator muscle, encased in fatty tissue. The nerve crosses the obturator internas, the two gemelli, and the quadratus femoris before disappearing beneath the femoral attachment of the gluteus maximus. You can find the nerve line on the short external rotators, and it can be easily palpated. Do not dissect to see the nerve. You may cause unnecessary bleeding from the vessels lying in the fat around it. Figure 8-56. Internally rotate the hip to put the short external rotator muscles on a stretch, making them more prominent, and to pull the operative field farther from the sciatic nerve. Figure 8-57a. B. Insert stay sutures into the piriformis and obturator internus tendons, just before they insert into the greater trochanter. Detach the muscles 1 centimeter from their femoral insertion and reflect them backward, laying them over the sciatic nerve to protect it during the rest of the procedure. Figure 8-57c. The upper part of the quadratus femoris rarely may also have to be divided to fully expose the posterior aspect of the joint capsule, but the muscle contains troublesome vessels that arise from the medial circumflex artery. Normally, it should be left alone. The posterior aspect of the hip joint capsule is now fully exposed. The hip joint capsule can be incised with a longitudinal or T-shaped incision. Dislocation of the hip is achieved by internal rotation after capsulotomy. Figure 8-58. Posterior joint capsulotomy will have exposed the femoral head and neck. Figure 8-54a. Skin incision for the posterior approach to the hip joint. B. Incise the fascia lata. Figure 8-55 Retract the gluteus maximus to reveal the fatty layer over the short external rotators of the hip. Figure 8-56 Push the fat posteromedially to expose the insertions of the short rotators. Note that the sciatic nerve is not visible. It lies within the substance of the fatty tissue. Place your retractors within the substance of the gluteus maximus superficial to the fatty tissue. Figure 8-57a. B. Internally rotate the femur to bring the insertion of the short rotators of the hip as far lateral to the sciatic nerve as possible. C. Detach the short rotator muscles close to their femoral insertion and reflect them backward, laying them over the sciatic nerve to protect it. Nerves. The sciatic nerve is rarely exposed or transected during this approach. However, it is sometimes involved in major complications. It can be damaged if it is compressed by the posterior blade of a self-retaining retractor used to split the gluteus maximus. Always keep the retractors on the cut surfaces of the rotators. The muscles will protect the nerve. The sciatic nerve sometimes divides into its tibial and common peroneal branches within the pelvis. On occasion, you may expose these two sciatic nerves during this approach. If you have identified the sciatic nerve but think that it looks too small, search for the nerve's other branch. It is in danger if it is overlooked. Vessels. The inferior gluteal artery leaves the pelvis beneath the piriformis. It spreads cephalate to supply the deep surface of the gluteus maximus. Its branches are inevitably cut when the gluteus maximus is split. You can identify and coagulate them before they are avulsed if you are dissecting carefully. The main trunk of the artery is vulnerable as it emerges from beneath the lower border of the piriformis when pelvic fractures involve the greater sciatic notch. If it retracts into the pelvis and bleeding is brisk, turn the patient over into the supine position, open the abdomen, and tie off the artery's feeding vessel, the internal iliac artery. Figure 8-58 incise the posterior joint capsule to expose the femoral head and neck. How to enlarge the approach. Local measures. 1. Enlarge the skin incision. Obese patients may have a considerable layer of subcutaneous tissue over the buttock that restricts deep exposure. Lengthening the skin incision and dissecting subcutaneously can compensate for this problem. 2. Extend the facial incision superiorly and inferiorly. 3. Detach the upper half of the quadratus femoris. Because the muscle contains troublesome vessels, it should be divided about 1 centimeter from its insertion to make hemostasis easier. Its excellent blood supply is useful both when the muscle is transposed and in treatment of some cases of non-union of femoral neck fractures. Figure 8-59. 4. Detach the insertion of the gluteus maximus tendon from the femur to increase the exposure of the femoral neck and shaft. This maneuver is particularly useful during total joint replacement, especially revision joint replacement. If you detach the tendon, position acetabular retractors on the rim of the acetabulum as you would in the anterolateral approach. As long as the retractors are firmly on bone and do not crush soft tissues against the acetabular rim, no vital structures will be damaged. See Figure 8-59. Figure 8-59 to gain additional exposure. Cut the quadratus femoris and the tendinous insertion of the gluteus maximus. Apply surgical anatomy of the posterior approaches to the hip and the acetabulum. Overview. The muscles covering the posterior aspect of the hip joint form 2 sheets or layers. The outer layer consists of the gluteus maximus. The inner layer consists of the short external rotators of the hip, the piriformis, the superior gemellus, the obturator internas, the inferior gemellus, and the quadratus femoris. The sciatic nerve runs vertically between the 2 layers, down through the operative field figs. 8-60 and 8-61. The gluteus maximus sits on the other structures in the buttock like the front cover of a book. It inserts partly into the iliotibial band and partly into the gluteal tuberosity of the femur, also inserting into the band, but further anteriorly, is the tensor fasciae lati. Together, the gluteus maximus, the fascia lata which covers the gluteus medius, and the tensor fasciae lati form a continuous fibromuscular sheath, the outer layer of the hip musculature. See Figure 8-60. As Henry 14 noted, the layer can be viewed as the pelvic deltoid. It covers the hip much as the deltoid muscle covers the shoulder. The outer layer can be breached at different points, each of which changes the posterior approach. Most natural separation, the Morrissey-Fletcher approach. 15 lies at the anterior border of the gluteus maximus, between the gluteus maximus inferior gluteal nerve and the gluteus medius. This approach uses a true internervous plane. Other more posterior approaches like the Moore approach and the Osborne approach 16 involve splitting the fibers of the gluteus maximus. They are more popular than the Morrissey-Fletcher approach even though they do not operate in an internervous plane, mainly because they offer excellent exposure of the hip joint. Figure 8-60 the superficial musculature of the posterior approach of the hip joint. The gluteus maximus predominates. Gluteus maximus, origin. From posterior gluteal line of ilium and that portion of the bone immediately above and behind it, from posterior surface of lower part of sacrum and from side of coccyx, and from fascia covering gluteus medius. Insertion, into iliotibial band of fascia lata and into gluteal tuberosity. Action, extends and laterally rotates thigh. Nerve supply, inferior gluteal nerve. Figure 8-61 the gluteus maximus and the gluteus medius have been resected to reveal the gluteus minimus, the piriformis, and the short rotator muscles. Note the relationship of the neurovascular structures to the piriformis, gluteus minimus, origin, from outer surface of ilium between anterior and inferior gluteal lines. Insertion, into impression on anterior border of greater trochanter tendon that gives expansion to joint capsule. Action, rotates thigh medially and abducts it. Nerve supply, superior gluteal nerve, piriformis, origin, from front of sacrum via fleshy digitations from second, third, and fourth portions of sacrum. Insertion, into upper border of greater trochanter round tendon. Action, rotates thigh laterally and abducts it. Nerve supply, branches from first and second sacral nerves. Obturator internas, origin, from inner surface of anterior lateral wall of pelvis and from surfaces of greater part of obturator foramen. Insertion, onto medial surface of greater trochanter above trochanteric fossa. Action, rotates thigh laterally. Nerve supply, any nerve from sacral plexus, quadratus femoris, origin, from upper part of external border of tuberosity of ischium. Insertion, into upper part of linea quadrata, the line that extends vertically downward from intertrochanteric crest. Action, rotates thigh laterally. Nerve supply, branch from sacral plexus. Figure 8-62 the gluteus minimus, piriformis, and short rotators have been resected to uncover the posterior aspect of the hip joint. Landmarks and incision. Landmarks. The greater trochanter, over which the skin incision is centered, is the easiest bony prominence to palpate around the hip. Its posterior aspect is relatively free of muscles. Its anterior and lateral aspects are covered by the tensor fasciae lati and the gluteus medius and minimus muscles and are much less accessible. The greater trochanter arises from the junction of the neck and the shaft of the femur. From there, it projects both upward and backward. Figure 8-63. The following 5 muscles insert into it. 1. The gluteus medius attaches by a broad insertion into its lateral aspect. Below this insertion, the bone is covered by the beginnings of the iliotibial tract. Bursa, occasionally a site of inflammation, lies between the tract and the bone over the relatively bare portion of the trochanter. The bursa can be the site of bacterial infection historically, most frequently tuberculosis. 2. The gluteus minimus is attached to the anterior aspect of the trochanter, whereas tendon is divided in the anterolateral approach. See Figs 8 to 61 and 8 to 62. 3. The piriformis inserts via a tendon into the middle of the upper border of the greater trochanter. See Figs 8 to 61 and 8 to 62. 4. Obturator externus tendon. Immediately below the insertion of the piriformis lies the trochanteric fossa, a deep pit that marks the attachment of the obturator externus tendon. See Figs 8 to 61 and 8 to 62. 5. The obturator internus tendon inserts with the two gemelli into the upper border of the trochanter, posterior to the insertion of the piriformis. See Figs 8 to 61 and 8 to 62. Incision. The upper part of the incision crosses the lines of cleavage of the skin at almost 90 degrees, but the resulting scar is always hidden by clothing. Most patients who undergo this approach are elderly and tend not to form exuberant scar tissue, and they heal with a fine line scar. 8 to 63. Osteology of the posterior aspect of the hip. Superficial surgical dissection and its dangers. Superficial dissection consists of cutting through the outer muscle layer by splitting the fibers of the gluteus maximus, the single largest muscle in the body. The fibers of the gluteus maximus are extremely coarse. They run obliquely downward and laterally across the buttock. The muscle's innervation, the inferior gluteal nerve, emerges from the pelvis beneath the inferior border of the piriformis and almost immediately enters the muscle's deep surface close to its medial border, its origin. From there, the nerve's branches spread throughout the muscle. Splitting the gluteus maximus close to its lateral insertion does not denervate significant portions of the muscle, because its main nerve supply passes well medial to the most medial point of splitting. See Figure 8-60. Gluteus maximus is quiet during normal walking or standing still. It comes into play during stair climbing or standing up from a sitting position. During normal walking, hip extension is primarily a function of the hamstrings rather than the gluteus maximus. Deep surgical dissection and its dangers. Deep dissection consists of incising some portion of the inner muscular layer, the short external rotators of the hip, to expose the posterior hip joint capsule. See Figure 8-55. 5 muscles form the inner layer: the piriformis, the superior gemellus, the tendon of the obturator internus, the inferior gemellus, and the quadratus femoris. Recognizing the relationship of the piriformis to passing structures is the key to understanding the neurovascular anatomy of the area. See Figure 8-61. All neurovascular structures that enter the buttock from the pelvis pass through the greater sciatic notch, either superior or inferior to the piriformis, which itself passes from the pelvis to the buttock through the notch. The 10 critical neurovascular structures are as follows. These are the only structures to pass above the piriformis, hence, they're named superior. 3. Inferior gluteal nerve. 4. Inferior gluteal artery. 5. Pudendal nerve. 6. Internal pudendal artery. 7. Nerve to obturator internus. 8. Sciatic nerve. 9. Posterior femorocutaneous nerve. 10. Nerve to quadratus femoris below the piriformis. The superior gluteal nerve emerges from the pelvis above the piriformis. It crosses behind the posterior border of the gluteus medius and runs in the space between the gluteus medius and the gluteus minimus, supplying both before sending fibers to the tensor fasciae lati. Superior gluteal artery, the largest branch of the internal iliac artery, enters the buttock above the upper border of the piriformis and runs with its nerve, supplying the gluteus medius and gluteus minimus and sending a nutrient vessel to the ilium on the gluteal line. The nutrient vessel may bleed when a larger posterior iliac bone graft is taken. The superior gluteal artery also sends branches to the overlying gluteus maximus, forming part of the muscle's dual arterial supply. The superior gluteal artery can be damaged in pelvic fractures, especially in those involving the greater sciatic notch. If it retracts into the pelvis, its bleeding must be controlled by an extraperitoneal approach to the pelvis so that its feeding vessel, the internal iliac artery, can be ligated. In pelvic fractures, selective angiography may aid in the diagnosis of a ruptured superior gluteal artery. During the angiography, the artery may be embolized through the diagnostic cannula, avoiding a pelvic exploration. 17. If you are using the anterior or posterior approaches to the acetabulum using a trochanteric osteotomy, the superior gluteal vessels must be intact in order to avoid muscle necrosis of the gluteus medius and minimus. This is because the origin and insertion of the muscles is detached in these approaches. If the acetabular fracture involves a displaced fracture of the greater sciatic notch, preoperative angiography is advised to ensure that the neurovascular pedicle to these structures is intact. The inferior gluteal nerve reaches the buttock beneath the lower border of the piriformis. It enters the deep surface of the gluteus maximus almost immediately. The inferior gluteal artery, which follows the inferior gluteal nerve, supplies the gluteus maximus. The branch it sends along the sciatic nerve was the original axial artery of the limb. In rare cases, this artery can serve as one guide to the sciatic nerve during surgery. The inferior gluteal artery may also be torn in pelvic fractures, but not as frequently as the superior gluteal artery. The pudendal nerve is not encountered during the posterior approach to the hip because its course in the buttock is very short. It turns around the sacrospinous ligament before entering the perineum. The internal pudendal artery runs with the pudendal nerve. The artery is usually well clear of the operative field during posterior approaches, but damage to it has been reported. Local pressure against the ischial spine usually controls bleeding. If not, or if the artery has retracted, an extraperitoneal approach through the space of recess 18 may be needed to ligate the parent trunk. The nerve to the obturator internus enters its muscle almost as soon as it emerges from behind the inferior border of the piriformis. The nerve also supplies the superior gemellus. The massive sciatic nerve, which is formed by roots from the lumbosacral plexus L4, L5, S1, S2, S3, appears in the buttock from beneath the lower border of the piriformis, just lateral to the inferior gluteal and pudendal nerves and vessels. It is usually surrounded by fat and is often easier to feel than to see. It passes vertically down the buttock together with its artery, lying on the short external rotator muscles of the inner muscular sleeve, the obturator internus, the two gemelli, and the quadratus femoris. Farther distally, it passes deep interior to the biceps femoris and disappears from view, lying on the adductor magnus. The sciatic nerve is safe during posterior approaches as long as you are aware of this position. It can be injured if it is trapped in the posterior blade of the self-retaining retractor that holds the fascial edge. It also can be damaged if it is not protected during reduction of the prosthetic head into the acetabulum. The tibial portion of the sciatic nerve supplies all the hamstring muscles except the short head of the biceps femoris and the extensor portion of the adductor magnus in the thigh. All its branches arise from the medial side of the nerve. Dissections around the sciatic nerve in the thigh therefore should remain on the lateral safe side, since the only branch coming off that side runs to the short head of the biceps, a muscle that causes few clinical problems if its nerve supply is damaged. See figure 8-61. The common peroneal and tibial nerves, the terminal branches of the sciatic nerve, supply all the muscles below the knee. In addition, they and other sciatic branches supply skin over the sole of the foot, the dorsum of the foot except for its medial side, and the calf and lateral side of the lower leg. Damage to the sciatic nerve at the level of the hip joint injures both tibial and common peroneal elements, resulting in a balanced flaccid paralysis below the knee, together with paralysis of the hamstring muscles. Complete sciatic nerve lesions are relatively rare. More often, the damage seems to affect either the tibial or the common peroneal components. Hence, neurologic findings may vary regardless of the level of the lesion. Common peroneal nerve palsies do occur after posterior approaches to the hip. The question then arises as to whether the nerve was damaged at the operative site or whether it was compressed by external pressure on the nerve as it winds around the neck of the fibula. The differential diagnosis can be made by doing an electromyogram EMG of the short head of the biceps, the only muscle of the thigh that is supplied by the common peroneal division of the sciatic nerve. Lesions in the pelvis or at the level of the hip joint denervate this muscle. Lesions at the level of the fibular head leave it unaffected. Only 20% of the cross-section of the sciatic nerve at the hip joint is formed by nerve fibers. The remaining 80% is made up of connective tissue. Nerve repairs in this area are often unsuccessful because bundle-to-bundle contact is difficult to achieve. The posterior femorocutaneous nerve of the thigh supplies a large area of skin on the back of the thigh. The nerve actually lies on the sciatic nerve until the sciatic passes deep to the biceps femoris. Then the posterior femorocutaneous nerve continues superficial to the hamstring muscles but deep to the fascia lata, sending out several cutaneous branches. The nerve to the quadratus femoris emerges from the pelvis behind the sciatic nerve and runs with it on its deep surface as it crosses the tendon of the obturator internus and the two gemelli. The nerve then passes deep to the quadratus femoris before entering its anterior surface. It also gives off muscular branches to the inferior gemellus. Obturator internus. The obturator internus is one of the few muscles that make a right angle turn. It curves round the lesser sciatic notch of the ischium. The muscle has a tricipital tendon that is reinforced at its insertion by the superior and inferior gemelli. Quadratus femoris. Femoris is quadrate, that is, four-sided. Running fibers form a clear surgical landmark. The muscle has an excellent blood supply. At the lower border of its insertion lies the cruciate anastomosis, consisting of the ascending branch of the first perforating artery, the descending branch of the inferior gluteal artery, and transverse branches of the medial and lateral femoral circumflex artery. See figure 861. The muscle's blood supply can be used to revascularize an avascular femoral head and neck. 13. In this maneuver, the quadrate tubercle of the femur is detached, leaving the muscular insertion of the quadratus femoris intact. The resulting muscle bone pedicle can be swung upward, and the bone can be inserted across the fracture site. Medial approach to the hip. The medial approach, attributed to Ludloff, 19, was originally designed for surgery on flex, abducted, and externally rotated hips, the kinds of deformities caused by certain types of congenital dislocation of the hip. The uses of the medial approach include the following. 1. Open reduction of congenital dislocation of the hip. The approach gives an excellent exposure of the psoas tendon, which can block reduction of the hip. 20. 2. Biopsy and treatment of tumors of the inferior portion of the femoral neck and medial aspect of proximal shaft. 3. Psoas